All right. Well, as usual, I don't have any financial disclosures. I'm going to talk about cardiac neoplasms and other types of masses, and they're rare. So, there's probably only going to be a few questions on boards, maybe one or two or three at most for these. The echo is often the initial modality that we see these on, and many times it's an incidental finding, and it requires help from our colleagues in radiology with complementary imaging modalities by CT and MRI. And I would say that half the time when you get these masses, you're not really wanting to see them because you didn't order the echo to look for a mass. You ordered it for something else, and then you have this neoplasm you have to deal with. And so if you stick with this lecture for long enough, I'm going to try to give you some clues on how to differentiate different masses that you need to worry about, ones that you don't need to worry about, and ones that may be artifact. And again, I do think this is one of the areas where it does boil down to needing multiple different modalities to image in. Now, this is actually backed by popular demand. A friend of ours over in the audience was asking me about this. So if any of you want it, I could probably email it to you later. So let's go on. I'm just going to talk about common cardiac neoplasms and tumors, and they can be benign or malignant or pseudomasses. I'm going to talk about the classic features, mobility, position, and what the differential diagnosis is. And then in the end, remember, we're only making our best guess. These are not, we can't make a pathology diagnosis with ultrasound no matter how good our observation skills are. So these are the common masses that we'll run into in our clinical practice. You've already had complete lectures on thrombus and vegetation. I'm going to concentrate on neoplasms for the most part and artifacts. So the clinical presentation is often embolic arrhythmic or heart failure. Some of these, some types of tumors, as you know, will cause some systemic symptoms such as fever, weight loss, chest pain, obstruction. If someone comes in with syncope, or either because of a valve being obstructed or because of a chamber or venous flow into or out of the heart, venous flow into or arterial flow out of the heart, and compression. And I think the scariest ones are the incidental ones that we find. Now, another very important point is that 40 times more common are metastatic disease to the heart. So I'm going to start there. These are secondary neoplasms that metastasize to the heart. And when you're talking about heart neoplasms, metastatic disease is the most common. They can get there from blood flow. They can get there for direct extension just by the things that live next to the heart, or lymphatic flow, or hematogenous flow. And I've listed them there for you so you can get an idea of those structures, particularly the GU and the GI, such as renal cell cancer and that type of thing that can travel through the vein to the heart. So the sites of metastatic neoplasms are coming from very different locations, and different series have been published about what's the most common. Melanoma is probably the most common in all series, followed closely by breast, lung, and lymphoma. Now, in two series, thyroid, which lives right next to the heart, was also metastatic to the heart, but thyroid cancer is a very rare cancer in terms of being metastatic to the heart in general. Now, this is a 72-year-old male who had dyspnea, syncope, and fatigue, and you can see why he might have syncope. You can see on the right atrium here this almost softball-sized mass that ball valves down right on the tricuspid valve, causing lack of flow across the tricuspid valve into the right ventricle. And on the left side, you can see this very dark melanotic-looking tumor that turned out to be cardiac melanoma. And this was removed, and he did well for several months, but in general, most metastatic disease to the heart has a very poor prognosis, and I don't think I'm going to show it now, but in your syllabus I have some of the references to how very poor the prognosis can be. Now, here's a situation, an 82-year-old gentleman that was referred for dyspnea and edema to the echo lab, and what we saw was a large mass in the right atrium. So this is Mayo format with the right ventricle, right atrium, left ventricle. You can see a little bit of the outflow tract, and right here along the, just above the tricuspid valve in the right atrium near the septum is a mass. And the first thing that you should do whenever you see a mass like that is go to the subcostal window and look at the hepatic vein. And it's subtle, but as you see, there's some a little bit of blood flow. Here's the liver, and here's the inferior vena cava, and you can see the inferior vena cava has something in it. And that turned, so what would you do next after you've seen this patient? Just shout it out, somebody. I'm not going to do an audience response for interest of time. So CT or MR. So that's what was done, and you can see that coming from the kidney over through the renal vein, in through the vena cava, and up into the right atrium was metastatic renal cell cancer, which is a tumor extension or a tumor thrombus from the renal vein into the right atrium. And here's another situation with a 64-year-old female with a history of breast cancer. She was declared a chemotherapy cure, but afterwards she presents, 19 years after she's been cured, quote unquote, she presents with an ischemic foot, so we were asked to do a source of embolism evaluation, and we saw this very ugly mobile mass along the atrial septum, or ventricular septum down in towards the apex, but all along the septum, broad mass, highly mobile, lots of little extra mobile components, and this was what was pulled out, and under the microscope it turned out to be metastatic breast cancer. 61-year-old RN with chest pain presents with possible STEMI, was sent here for STEMI protocol, but when they did their coronary arteries, they were normal, and you can see why they might have thought it was a STEMI with significant ST elevation in the inferior and in the lateral leads. So after her coronary angiogram was done, we got an echocardiogram, and this is what we saw. And this is also the type of restrictive cardiomyopathy that I mentioned I'd show you in this talk. So what you'll see here, left ventricle, right ventricle, and it's not moving. Normally you don't see this much, so it's enlarged. And then you see how it's just sort of standing still here. It's very thickened, and you can see there's a little bit of tricuspid regurgitation, but it doesn't move. It's standing still. When we do a CT scan, you can see that there's very much of a mass that's infiltrating the entire inferior wall, the right ventricle, the lateral wall, the inferior septum, the inferior wall, the left ventricle, and that is, unfortunately for this lady, was metastatic breast cancer. And that's how she presented as a STEMI. She didn't know she had breast cancer. Primary malignant neoplasms can be found rarely. I've just shown you a bunch of metastatic ones. Now we're going to talk about primary metastatic or primary cardiac neoplasms, and it includes angiosarcoma. And honestly, I really think that if they do test you on this, they're going to test you on angiosarcoma. Any of the benign tumors can become sarcomatous and show up as a metastatic tumor. And then keep in mind, lymphoma is the other one that can start in the heart, primary cardiac lymphoma. And this will be in your syllabus for your review, but the position of these things is really what helps us in the echo lab. And then ultimately, you're going to need to get some tissue to biopsy to determine what the tumor is. One thing I'll point out again, I think angiosarcoma and lymphoma, there'll be the two that you'll have to think about. Angiosarcoma tends to be along the right heart border and the AV groove. Lymphoma tends to show up in the atria. Angiosarcoma tends to have this pericardial extension, which I'll give you some examples of. So here's an example of primary cardiac angiosarcoma. And you can see this mass. It's really coming in from the dome of the right atrium, again, male form at right ventricle, right atrium, and you have this mass. When you see it on the MR scan, you can see how very enlarged. We're seeing just this portion of it here, and there's a tremendous enlarged tumor mass on the outside of the ventricle. Angiosarcoma often starts in the atria, right atrium greater than the left atrium, associated with a pericardial effusion. This is a very bloody. These are masses of veins and vessels that are very friable, and they tend to rupture, and then they bleed into the pericardial space, and can also often present with tamponade. So the key points, and the reason I made a key slide on this one is because I think if they're going to test you on masses, these are the key things you're going to want to remember. The atrial location, the bloody pericardial effusion, very poor prognosis, and that you can get biopsies. Think about percutaneous biopsy. I have an example of that, but in the interest of time, I'm not going to show it today, of where you can actually go up with catheters, bioptomes, especially right-sided masses, and get a piece of this and save the surgery. Primary cardiac neoplasms that are benign are much more common. 94% of our primary cardiac neoplasms will be benign rather than malignant. And so if you see a mass, you know, this is more often than not, if it's coming from the heart, it's going to be the benign type. And these are the most common. I have a chart for you. Again, I've put it into your syllabus. This was based, I just point out, on autopsy data, not on echocardiographic data. And I would submit that for boards, you should always answer, if they ask you this question, what's the most common tumor? It's myxoma, based on autopsy studies. But if you reflect on your own practice, I bet you're going to say it's something else. And the something else's are papillary fibroblastoma and lipomas. And those are probably more common ante-mortem. But let's talk about myxoma for a few minutes. It's the most common primary cardiac tumor as far as when you're talking about board examinations or an autopsy series. It's located in the atria, often the left atrium, with with the attachment being the atrial septum. It does lead to very catastrophic events such as systemic emboli, arrhythmias, and requires really surgical management. If its location is atypical, in other words, not in the atria and not along the atrial septum, you need to think about syndrome myxoma. The smooth type reportedly is less likely to embolize than the papillary type, but I think in general it doesn't really matter. Once you've identified something that you think is a myxoma, it needs to be removed. And here's an example of a very large myxoma. You can see how these things can cause obstruction to the valve and syncope, atrial fibrillation. And as the surgeon has to be very careful to look on both sides when they inspect to make sure that there's not an extension of this tumor into the right atrium, because that will recur. And then also to very carefully get the entire base of the myxoma, again, so it doesn't recur. But if it's a sporadic myxoma and you get the entire base, it should potentially be just a one-time event and not recur. And here's this very large mass. It looks a little bit like a group of grapes in that view to me. Maybe you wouldn't want to make wine with it, though. Bad joke. So myxoma, I mentioned the syndrome myxoma, Carney syndrome. This is an important thing to keep in mind. Myxoma in Carney syndrome are multiple. These patients will have a family history. There's actually been genes located on chromosome 2 and 17, and it's an autosomal dominant. It's been associated with all of these things, and sometimes people think that it's a multi-endocrine neoplasia, testicular cancer being one of the more common neoplasms that it's associated with. And the thing that you'll see is these lentigines on the face of kids and adults where they are looking like freckles, but they're really on the cheeks and on the eyelids and places where the sun doesn't hit as much. So these are, and on the lips, right across the border of the lips. And therefore, if you see very atypical freckle pattern, think about syndrome myxoma. The diagnosis, then, here's the key summary points. You'll be 95% of the time if it's in the left or right atrium and attached by a stalk to the atrial septum. Keep in mind that the differential diagnosis of myxoma is thrombus, papillary fibroblastoma, lipoma, and metastases. And if you have any endocrine abnormalities or history of atypical location or Carney syndrome, then you may have Carney syndrome or the syndrome myxoma. Genetic testing may be warranted. The most common cardiac neoplasm in kids is the rhabdomyoma. It's often you can see it's multiple. Here's one right here. It almost looks like it crosses, like a vegetation might be invading, but there's a little tumor in the left ventricular outflow tract. Part of the neoplasm is actually in the right atrium. And in the same patient, you can see down in the ventricle that there's and this is a congenital format with left ventricle. Down here, there's another mass. The interesting thing about these is that they're associated with tuberous sclerosis. They can be multiple, but they will regress. So unless they're causing a problem that needs immediate treatment, for example, obstruction of a chamber, then you probably can just wait till the child matures and they'll regress enough that they won't cause a problem. This is an example of the tubers that you can see in tuberous sclerosis. The classic triad is seizures, mental retardation, facial angiomas, and it's an autosomal dominant inheritance pattern. Fibroma, again, pretty uncommon, even though in the autopsy series, it's supposed to be the second most common, but fibromas are very unusual. You see one in the right ventricle here and the left ventricle. They're characterized by this little calcified area. You can see little dots of calcium. If you zoom up on them, they'll become more clear. Let's talk about masses that are usually on valves. We'll start out with papillary fibrillastoma. It's an avascular structure. It's usually a single layer of endothelial cells that surrounds these fronds, and there are multiple fronds. And underneath that single layer of endothelial cells, you have elastin, collagen, a little bit of smooth muscle cells from time to time, and it's this myxoid colloid that they're in. And we really don't know what the origin is, but you can see how complex these structures can be, and in 95% of the cases, they will be attached by a stalk. Here's an example of an electron micrograph. Again, just emphasizing they are often described as a sea anemone. The complexity and the reason why you can imagine little platelet thrombi lodging between those fronds. Here's a classic example of a papillary fibrillastoma. They're not always this easy to spot, but if you see this, and this would be what I would expect them to give you on the boards, they will have this very mobile mass. It's attached by a little thin stalk, short stalk in this case, but I think you can definitely appreciate that it is there. And those are easily snipped off. I'm not going to ask you what you would do, but those are the things that have come into conversation about what you would do. So what would you do? Just yell it out. I'm not going to do a surgery. Okay. That's not how we always used to answer that, but yes, I would agree, surgery. We didn't want to put catheters in to look at her coronaries, so we did a CT coronary angiogram. She had normal coronaries, and again, I think beautiful representation of the stalk. And here's her intraoperative picture. They did a shave excision with just minimal residual aortic regurgitation, and this is in your syllabus for reference so that you can see that these are very easily removed in the skilled hands of our surgeons. In the group that was incidentally found, which is 41 patients, it was very unusual to have to repair or replace the valve. 3D echo can help us when these are on the mitral valves. Here's an example of a papillary fibrillastoma on the anterior leaflet of the mitral valve, and you can see it's in the middle scallop of the anterior leaflet of the mitral valve on 3D. Again, noticing that they're very complex. And more recently in our practice, and Crystal actually published our first few cases of this. This is one of the cases where we can remove them with robotic help. And again, because they just come off, when I was a fellow doing some research on these masses, we used to try to run down and get them from the surgeon before he removed them. And a few times they sucked them off the valve with a sucker as opposed to snipping them off. They aren't attached they're not very difficult to excise from the valve, and they can usually be left with the valve in good shape. The differential diagnosis is as quite broad as you can see. So when you see masses, and if they're not exactly classic like the one I showed you, you need to think about other things you can do to rule out the differential diagnosis. Remember, myxoma we'd probably want to remove anyway. Lambos we want to leave alone, and I'll go into that. And one of the more common things in the series that we presented at the American Society of Echo last year, when we did send these patients to surgery, that they were not papillary fibrillastoma. It often was non-bacterial thrombotic endocarditis, and that is something that you can explore by getting these special coagulation studies, anticardiolipin antibody, looking for Liebman-Sachs endocarditis with anti-nuclear antibody and lupus anticoagulant. So what do we do with PFE in our practice? We tend to remove it if the patient's a surgical candidate and it's on the left side. If it's on the right side, we tend to watch those because they usually don't cause any valvular problems if they're on the valve. But remember, they can be on any other endocardial service, not just the valves. And these are the tests that I would recommend you get. Sometimes we watch them on anticoagulation if there's any reason to think that these are thrombi. You can treat them expectantly with anticoagulation with Coumadin if you're worried about Liebman-Sachs, and sometimes they'll get smaller and disappear. So it's not unreasonable to treat them for a few months with anticoagulation. Again, I just put together a key slide for you in terms of your studying. One of the problems is they're often incidentally found, and then what do you do? These are the ones where everyone says, I don't really want to see that on the echo. I wasn't looking for that. But these are an opportunity to prevent a stroke in patients with these masses. Immune-mediated valvular heart disease, which the non-bacterial thrombotic endocarditis can be either due to an underlying malignancy, lupus, or antiphospholipid syndrome. And these would all be the type of testing and workup that you would do if you have an atypical papillary fibrillastoma. These are the things you want to look for, and sometimes you'll find those. Now here's a patient with pancreatic cancer who suffered a CVA. And what I'm showing you is the motion images, and if you're not careful, you'll miss very easily non-bacterial thrombotic endocarditis because they're subtle. So you can see when you do a still frame or play it in cine, each one of the cusps of the aortic valve had a small mass attached to it that was one of these highly friable thrombi that in this particular case unfortunately was associated with catastrophic strokes that kept recurring. So here's a patient, you're on a busy day in the OR, and Dr. Suri comes up to me and says, okay, Kyle, I see you're doing TE. Try not to be too, don't see any unusual masses because I have this reputation in the OR that I always find these things. So what do you see on this valve and what would you do about it? Would you bury your head and just hope the anesthesiologist doesn't know anything about echo? Would you do nothing because there's nothing to do? Would you put on your lead armor and tell the surgeon there's a tiny mass? Now, if you guys came to this lecture last year, I changed this case. So don't, it's very subtle. Can you see it? Okay, it's hard because it's maybe not projecting as well. So what is it? It's a Lambles. Well, he happened to be there anyway, so he took it off. Lambles. Lambles excrescences are pathology very similar to papillary fibrillostoma. They're often on the aortic valve, less so on the mitral valve, and they increase with age. They're a degenerative process, and there's data to suggest that in general they don't cause embolization, although I know some retrospective studies have suggested that, but data from our SPARC data here would say that these are degenerative and don't need to be removed. These are another thing that can sometimes be confused as a fenestration. This is another degenerative finding. You can see this wiggly, highly refractile linear echo density above the aortic valve that is, again, something that probably won't come off the valve. It's when you have these friable little pieces that can break away from the valve itself. And oftentimes you'll see some aortic regurgitation. Here's another interesting mass. I'll let you take a look at this echo. 50-year-old gentleman who presented with dyspnea, severe tricuspid regurgitation by color flow, ends up in the TE lab because they thought they saw something on the tricuspid valve. Do you see something on the tricuspid valve? Okay. Is it 1, a blood cyst, 2, a heart within a heart? Or vegetation? Okay. I told you I wasn't going to talk about vegetation, so you're right, it's a heart within a heart. No, I'm just kidding. Blood cyst. And this is what a blood cyst looks like. And most of the time, our pediatric colleagues will tell us that these will go away over time, but in certain cases, and I think the reason this one persisted and maybe even became larger and weighted down the tricuspid valve, is there's channels into it. You can see there's a little bit of contrast in that, inside of that blood cyst. And so there's some channel leading to the cavity that let it get larger and cause, after many, many years, degeneration of the valve. And so now I'm going to switch gears. These are valves that have a propensity for the AV groove. And I'm going to go through a few of these now in order. Again, very rare masses in general. This pheochromocytoma, I bring it up because sometimes patients will present with the syndrome of pheochromocytoma with hypertension, headache, flushing, and you get the catecholamine tests, and then you see something light up in the heart, and this is usually how they present. So then you go to your echo, and these will be very echo-dense masses. They're well demarcated in the AV groove, and by echo subcostal, you see the liver here, right atrium, AV groove, and the right ventricle here, and this is this dense pheochromocytoma. Pericardial cysts, however, are not that uncommon, oftentimes seen by chest x-ray, and you'll end up looking at them by echocardiography. And you can see, again, our allied or our other imaging modalities, such as CT or MR in this case, will show the bright T1 weighted imaging. And the concern always comes up, is this a tumor or not? One of the things we can do in the echo lab is we can give contrast, and I guess maybe I took that slide out, but if you give contrast, what do you think this what will happen to our cyst there? Nothing, right? It will just be lighting up in the heart chambers, but the cyst itself will not light up. So that can help you out. Here's another AV groove mass. This is subcostal. Here's liver, right ventricle, right atrium, left ventricle. You see something here and here. Okay, it's a coronary artery aneurysm. That one was a chamber, you could also give contrast in this situation. Of course, we're giving it by cath now, but this is a very large cyst. You can see, or aneurysm, you can see it giant coronary artery aneurysm. So that's something else that can be in the AV groove. Again, couldn't probably necessarily make the entire diagnosis in the echo lab. You could consider it and give contrast, and if you have arterial contrast in there, you will see that there's an arterial structure. Lipomatous hypertrophy of the atrial septum, again, most of the time these aren't hard to figure out, but they can be massive, and as you can see in this MR, it's in the septum, it's in the dome of the right atrium, and it's in the right ventricular free wall. We can see them by TEE all the time, but what you're looking for is this dumbbell appearance of the superior and inferior limbus with a clear fossa ovalis membrane. And that's how you make that diagnosis. You won't be mistaken. And you can see a normal heart has a little bit of fat in the superior and the inferior limbus, and you can see that they not infrequently, especially with age, will lead to massive hypertrophy of the superior limbus of the fossa ovalis. And they're often associated with patients that have a lot of other epicardial fat in addition. Let's talk about masses and pseudomasses here. So what's this? Prominent, very mobile echo density here in the right atrium on TEE. We see these a lot. This is really a very prominent, maybe even would be considered a Chiari network, right? I mean, we can't tell for sure because we can't see if it's a network or not. On this side here, though, when you tilt the probe and you see it coming up to the fossa ovalis, as we're demonstrating here, even though it's very mobile, you can see that it comes towards the atrial septum, and that's clearly a prominent eustachian valve, or when they're really mobile like that, some people will call them a Chiari network. It's basically the same complex. So what's this? It's pectus excavatum, so it displaces the heart. Here's another potential. The sonographer here kept going back and forth. What's in this area? Well, what would you do to prove it? Okay, you guys are so good. So this is a diaphragmatic hernia. You tell the medical student to run down the hall, buy a Verner's if you're in Michigan, or Coke if you're here, and drink. And you wonder why you have reflux afterwards. But that's it. Those are bubbles. That's contrast coming from the pop that he just drank. You're tilting back and forth in the plane and catching the diaphragmatic hernia that's pushing up. And just being out of plane a little bit, you're catching that pseudomass. And you can see on the chest x-ray how prominent it was. So there's a lot of things to keep in mind about masses. Number one is papillary fibroblastomas, myxomas. If you can be clear that those are what you have, and I've given you the classic presentations, I recognize that they're not always classic. If they're not always classic, you need the history. So the location is very important. So this will be in your syllabus, but it'll help you out of most of the binds you'll run into on your boards, because I think they'll ask you classic things about these masses, not atypical things in general, with the exception of Carney's syndrome. I would definitely be familiar with Carney's syndrome. But always keep in mind the clinical history, because we can't really make a pathology diagnosis by ultrasound, no matter how good and how keen our observation skills are. And then keep in mind, if I had to know several, these are the masses I would really understand for boards. Location is very important, and I think if you have a good friend in radiology, fantastic, because they're great partners in terms of multimodality imaging to figure out these very difficult situations. If not, I would find one. Well, thank you for your attention. I'm happy to answer any questions later on, but I know Crystal's got a lot of great examples for us coming up.
Okay, Crystal. She is a graduate of our imaging fellowship and interested in the congenital heart disease. And also we have a sort of annual dance competition. She's one of probably the tallest faculty in CV, right? I'm probably the shortest faculty. So we decided to do at least dance once a year. So we do a holiday every time, and she comes to me, I have to dance. And so I get to know very well.
Like I have to force you.
Yeah,
Come
that's
on.
true. Actually, anyway, she is great, and she'll give you a nice questions, I'm sure. Okay, Crystal.
Thanks, Dr.
Okay,
O.
thank you, Chris.
Good morning, everybody. I have a bunch of cases, so we'll get through as many as we can, and I have no disclosures. First case, an 18-year-old woman with Cushing syndrome and multiple lentigines. So we'll see if you guys were all paying attention. So here's the transthoracic. This is Mayo Clinic format, so right ventricle, right atrium, left ventricle, left atrium. So what do you think the diagnosis is here? Okay, looks like you were all paying attention, or 56% of you were paying attention. The rest thought it was a metastatic adrenal tumor. Okay, so this is a myxoma, and I'll get to a few points about it in a second, but I just wanted to show you this was her 6-month follow-up echo. So she ended up having the myxoma resected out of the right atrium. Then she comes back 6 months later, and we saw this out here in the right ventricle. So not really a typical location for a myxoma. So we did a cardiac MRI. So I wanted to demonstrate the findings of myxoma on MRI. MRI can be very helpful. There's sort of some typical characteristic findings of myxoma. So on T1 weighted images, a myxoma usually looks about the same as myocardium. It will be iso-intense. On T2 weighted images, it will be very bright, and that's because it has a lot of water. It can be very heterogeneous because sometimes there's calcification or hemorrhage in there. And then if you give gadolinium, sometimes there's very heterogeneous enhancement. So you can see there's kind of a white spot in the middle of it, and then it's kind of black on the outside. So that's the typical findings of a myxoma. And this was a patient with Carney complex. And Dr. Klarich went over this, but the patient had multiple lentigines, she had Cushing syndrome, and patients with a familial myxomas typically have them in atypical locations. So that's kind of a clue for you, and it's probably less likely to be on the boards, but it's possible. And then I just summarized the other key points, and I won't read those all, but Dr. Klarich went over that. So we'll go on to the second question.
Answered malignant or metastatic mass. Was there another view that you would have liked to have seen? Subcostal, right. So if you see the subcostal in the echo lab and you don't see anything in the IVC, that helps you to think more in terms of myxoma when they're atypical location like that.
Yeah, good point. So this is a 48-year-old woman who presented with a TIA, and this is a transesophageal echo. So here are your options. Is that a myxoma? Is it a vegetation? Is it a papillary fibroelastoma? Or a blood cyst? Excellent. Okay, 86% got that. That's a papillary fibroelastoma. So what is the next step? And Dr. Klarich covered this, so you can just answer quickly here. She had a TIA, it's on the mitral valve, so should we resect it? Should we give her antibiotics? Should we do nothing, or should we get an MRI? Yay! Good job, Dr. Klarich.
Hasn't happened yet this course? First time? All right. We get a bonus, Crystal.
I agree. Excellent.
We get okay. We get 2 Mickey Mouse bars instead of 1.
All right. So key points with papillary fibroelastomas, they're benign. They usually don't cause valve destruction. So unlike endocarditis, the valve usually is intact and you just shave it off. And if you have embolic events, then you should excise them. And she went over how we can do that minimally invasive now, which is a really nice option for these patients. So next question, 59-year-old man with dyspnea and a recent diagnosis of polyarteritis nodosa. So this is a transthoracic, and again, Mayo Clinic format. So right ventricle here, right atrium here, something here, and then I'll show you a short axis at the level of the aortic valve here. So aortic valve, right ventricular outflow tract. Here there's something here, and then this is with color flow. So, do you think this is a pericardial cyst? Is it an angiosarcoma, pheochromocytoma, or a coronary artery aneurysm? Okay, so over half got coronary artery aneurysm. So it's kind of a tricky one. I'm not sure you can make that diagnosis from echo, but if you see that, and you see that in the groove there, the AV groove, you should get another imaging test. So in this case, we got a CTA. So here we are at the level of the aorta, right ventricular outflow tract. This is the LAD, and you can see it's a little bit bigger than it should be. Now, as we come down, circumflex is also a little bit bigger than it should be. But here, I want you to follow this area right here. This is the right coronary artery. And as we come down, you see it's quite dilated. And as we get down further here in the AV groove, there's a lot of thrombus in here. So this is a big right coronary artery aneurysm with thrombus in it. And you notice it's located right in that AV groove, right where we saw that on echo. So she discussed the differential for AV groove masses, and this is one of them you should think about, especially in this patient who had polyarteritis nodosa.
Could you go back to your echo image and
Yes.
just point out the anatomy for us?
Sure. Okay. So LV, RV, RA, right here in the AV groove, you see this big round mass. And then here at this short axis level, which is similar to that axial image that we're seeing, right here, this round mass here next to the aorta. So on our
In the color flow, do you think there was a little flow in there? If you go back?
a little bit. I think that
Yeah.
probably we could have turned the scale down.
Right, that was going to be the point. I think that there's a little
That
flow
looks
in
like
there.
there might be flow right there.
And if you see something like this, the two things you could do is, well, number one, just turn your color scale down to a lower rate, and you may bring out that color flow because it's going to be a little lower velocity than the flow that's in the ventricular chamber. And the second thing would be to possibly give contrast.
Right. So flip through that again. So you see right there in the AV groove, same kind of thing. So coronary artery aneurysms, incidence ranges from 0.3 to 5% depending on the series. The right coronary is the most common location, and atherosclerosis is the most common cause. But if you have an inflammatory or connective tissue disease, that's commonly associated. And then treatment depends on the patient's symptoms, where it's located, and options would be medical therapy versus bypass surgery versus a covered stent.
Crystal and Kyle, there's a question from the audience. When do you decide to start someone on anticoagulation when you see a mass, a cardiac mass?
Wow, that's a loaded question. I'll let Crystal take it. No. I think, if I have a mass, especially valvular masses that I worry are thrombi. And what I mean by thrombi, usually if you have normal LV size and function, normal flows, you shouldn't have thrombus spontaneously occurring on valves, with the exception of non-bacterial thrombotic endocarditis. And some of those will respond to anticoagulation. And so while I'm doing the workup, I may start a patient that I think has that on anticoagulation with Coumadin. Now, if you have a patient that you have what you think is a papillary fibroelastoma and they're not a surgical candidate, then those patients we tend to start on aspirin. And the reason for that is not there's really not any documentation out there to be able to guide us, but in our series that we published in 1996 and subsequently clinically, when we've looked at these under the electron microscopes, we've been able to see that there's little platelet thrombi that form between the fronds of papillary fibroblastomas. So in the first series that we published in 1996, there were 3 patients that had strokes while on Coumadin. And then subsequent to that, we started looking at them under electron micrographs, and also pathologically, Bill Edwards would tell you that these are all platelet thrombi, and antiplatelets seem to make sense, but there's probably never going to be a randomized trial. Although Charles thinks maybe we could do one.
All right, we'll move on. So this is a 59-year-old woman with metastatic breast cancer. She was admitted with atrial fibrillation with rapid ventricular response. So this is an apical 4-chamber view, LV, RV, LA-RA, and it was the area of concern. I'm going to show you one more image before we vote on what we think it is. So here's a subcostal view, right atrium, left atrium, and this was the area that they were concerned about, and there were multiple images taken. So what do you think that is? Is that thrombus? Is it metastatic breast cancer? Is it lipomatous hypertrophy of the atrial septum? Or is it a papillary fibroelastoma? She has breast cancer. She's in atrial fibrillation. What do you think it is? Good. I didn't fool too many of you. 61% are right. So this was kind of tricky, and the clinicians taking care of the patient were concerned because she was in atrial fibrillation. She did have metastatic breast cancer, and they said, well, there's kind of that little thing wiggling around right here. Are we sure that this is really just lipomatous hypertrophy of the atrial septum? So in this case, they actually went on and got a CT. And you can use either CT or MR to confirm this diagnosis. It did look like the typical lipomatous hypertrophy of the septum on echo, but because of the circumstances, there was concern. But typically on CT, it will be this homogeneous, very low attenuation. It looks like fat. And on MRI, it will look like fat as well with your different sequences. So on T1 weighted images, T2 weighted images, and you can give fat saturation to make it go away on MR to confirm it.
You really trust the CT and MR? I'm just kidding.
I wasn't the one who chose to get the CT.
But it looks unusual, that's why it's...
Yeah. All right, so 77-year-old man, mitral valve repair in the past. Now he presents with fevers, bacteremia, and stroke. So take a look here. And then we'll vote. What is the diagnosis? Is it thrombus? Is it infective endocarditis? Is it Liebman-Sachs endocarditis? Or is this normal post-op changes for a mitral valve repair? Okay, good. So 84% are correct. It's infective endocarditis. And so the key points for vegetation is that it's a discrete oscillating mass that's adherent either to the leaflet or to the prosthetic material in the valve that has independent motion from the valve. And typically, vegetations are located on the upstream side of the valve. So for the mitral valve in the left atrium, or for the aortic valve, it will be in the left ventricular outflow tract. They have this lobulated or amorphous appearance. And then you need to look for the associated findings, such as a perivalvular abscess or pseudoaneurysm. Look for dehiscence of your prosthesis, perivalvular leak, or significant valvular regurgitation. So next question. This is a newborn male who presents with a murmur. So we're starting subcostal here. So right ventricle, right atrium, left atrium. This is a short axis, parasternal short axis at the level of the aortic valve here. So this is the right ventricular outflow tract, pulmonary valve. And here's a parasternal long axis with color on this side and on the right side without color. Same image. So the question is, what syndrome is associated with this finding? Is it Down syndrome, tuberous sclerosis, neurofibromatosis, or Carney complex?
Jay thinks this is a good question.
Okay, good. So 73% of you are correct. So that's a rhabdomyoma associated with tuberous sclerosis. And now I'm going to show you the Doppler through the pulmonary valve here. So mean gradient is 6. Through the aortic valve, mean gradient is 4. And now I'm going to ask you, what would you recommend for this patient? Should we do an aortic valve replacement and a pulmonary valve replacement? Should we resect all of these masses? Should we just observe? Or should we biopsy to find out what's going on? Okay, good. 76%. All right, we're going to observe. So this patient has multiple rhabdomyoma. So these are benign tumors, and they're the most common tumors in children. And over half of them are associated with tuberous sclerosis, as most of you got. They're often multiple, and they usually do regress in both size and number over the years. They can be associated with an increased incidence of pre-excitation, and the only time you would ever excise any of them surgically is if there's significant outflow tract obstruction or if the patient's having refractory arrhythmias. So we'll move on. This is a 42-year-old man who presented with tamponade. He underwent pericardiocentesis. The fluid was bloody. And here's his subsequent transthoracic image here. You see there's still a little bit of effusion here. This is the right ventricle. This is the right atrium. Here's the area we're concerned about. And so the patient had this echo, and then they went on and did a transesophageal echo. So we're here at 90 degrees, left atrium, right atrium, obviously something here. So I'm going to have you go ahead and vote what you think this is. Is this likely to be thrombus? Is it a myxoma? Is it an angiosarcoma? Or is this metastatic renal cell cancer? And since I didn't show you the subcostal view of the IVC, you can probably guess it's not number 4. Okay, so 62% correct. Angiosarcoma. So this is an angiosarcoma. The clues in this case were the location, so it was in the right atrium, and the patient presented with a pericardial effusion, actually with tamponade, and a pericardial effusion was bloody. And as Dr. Klarich covered, this is the most common primary malignant tumor, and you can use echo guidance to do a biopsy of this in the cath lab. You can also do an MRI, and there's also some pretty typical features on MRI. So on T1 weighted images, here you see, again, similar findings to the myxoma where it's basically iso-intense to the myocardium, but you see it's more heterogeneous than the myxoma was. And then on the T2 weighted images, because of the fluid content, it's bright. Here you see the pleural effusions are bright, and you see that this mass is lighting up here. When we give contrast on the perfusion sequences, you can see that actually the contrast is perfusing into that highly vascular tumor. And then on delayed enhancement images, you see the same thing, sort of a heterogeneous picture. So MRI can be helpful in these cases as well if you're not sure what it is and you don't want to do a biopsy. So next question, 64-year-old woman with dyspnea. This is a transesophageal echo. So I'll show you, here's another image here. So this is the aortic valve. And then one more image here with color flow across the mitral valve. Now we'll go ahead and vote. Is that a thrombus? Is it a myxoma? Is it an angiosarcoma? Or is it lipomatous hypertrophy of the interatrial septum? Excellent, 99%, good. So that's a very typical myxoma. That's probably the classic thing that you'll see. So next question, 5-year-old girl presented with ventricular tachycardia and syncope. So left ventricle, something here, right ventricle. And then here's a subcostal image. So again, LV here. We're looking in this area. And then I'll have you vote. Is this a fibroma? Is it a rhabdomyoma? Is it an angiosarcoma? Or is it a myxoma? Okay, so I fooled some of you. So the correct answer is fibroma. I see most people went for rhabdomyoma. And rhabdomyoma is the most common tumor in children, but fibroma is probably the second most benign tumor in children. And it's typically very large, and the way to differentiate it from a rhabdomyoma is by these features. It's typically much larger, whereas I showed you that example of the rhabdomyoma where there were multiple tumors. The fibroma is usually just a one solitary large tumor. And it's often located in that LV free wall, but can also be located in the interventricular septum. And it typically has dystrophic calcification. It was kind of hard to see on that image. It was kind of overgained. But those are the major differences in differentiating the fibroma from the rhabdomyoma. So next question, 62-year-old man with coronary disease, congestive heart failure, and obstructive sleep apnea. So this is transthoracic, sort of zoomed up 4-chamber view, left ventricle, right ventricle here. And this is just a zoomed up view here looking at the apex. And here's a 2-chamber view. So what do you think's going on here? Is that a fibroma? Is it a thrombus? Is it artifact? Or is it a myxoma? Okay, so exactly, thrombus and artifact are the two things that you should be thinking about, and it's not fair of me to ask the question without giving you the next picture. So you guys were thinking the right way there. So the LV was down, the apex was hypokinetic or akinetic, and we saw that thing in the apex. So the next step you should do is give contrast. And so here we're giving contrast, and you can see there's some swirling out there, but there's no mass there. So that was an artifact out at the LV apex. But you really would need to give the contrast to prove that. So everyone was thinking the right way there. I kind of tricked you. So.
And the way the question would be framed is that it would probably ask you, one of the
Right.
options would be administer contrast to, to identify this.